Let us start for the day.
Yes, sir.
We'll take a look today at each school of psychoanalysis again, like last time, and look at each of the school as a unique analytic machine which accepts only a certain kind of input, which is both its specialization as well as its limitation, and which gives a particular kind of output, which is again both its specialization and its limitation. And therefore, it is very important to know which case history should be should we be taking for a particular given analytic machine, because every school of psychoanalysis will not accept the same kind of input for processing. So right from case history to the way we do pathogenesis to the way we actually do therapy, all of that is definitely a function of how much knowledge we have about each of these analytical machines. So we will take a look today at all of these schools as analytic machines and see what insights this approach gives us. So let us revise what we did last time so that we can have a continuity. Let us do some regression for consolidation. So one important slide we saw last time was this, that there are many approaches to healing. One classification is active healing and passive healing. If I go to a homeopath and he gives me medicines, it is passive healing. If I go to a psychiatrist, he gives me medicine, it's passive healing. The medicine goes inside and does all the work. I don't have to really involve myself much. If I go to a pranic healing person, he does pranic healing, again it's a passive healing. However, if I go to psychotherapy, I have to actively involve my thoughts, my emotions, everything. So it is an active healing. The patient is actively participating in the process of healing. And without his participation, the process of healing cannot work. Unlike in allopathy, unlike in homeopathy, which is sort of independent of the conscious participation of the patient. If I go for yoga, again, it has to be an active healing. If I go for tantra, again, active healing of a very different type, because the entire Western psychotherapy is based upon a principle reflecting, not acting. It's very important to know this. The entire world of Western psychotherapy is based upon this principle, reflecting, not acting. Meaning, if I am in therapy session and I feel a murderous impulse towards somebody, towards a therapist, let us say, I am free to tell the therapist that I want to kill you. I am free to feel all the rage in my body, but I am not free to stand up and slap him. I cannot act out. I cannot live out. I have to confine all my feelings to thinking and feeling while being on the couch or on the chair, whatever the mode of therapy. So it is based upon the principle reflecting, not acting. Tantra does not accept this principle. Tantra says living beyond reflecting, that it is not enough to just be in the world of thoughts and feelings. Unless you really live out something, you can't really transcend it. So it's a very different way of looking at human evolution or human healing. Meditation, if you do it yourself, again it becomes a uh, active participating thing. Yeah. Dr. Mukherjee, you had a question? Okay. So one way to classify healing is active and passive. Second way to classify healing is to look at the way healing happens. So you can have an analytical approach like we have in psychoanalysis. You can have a creative approach like we have in art therapy or play therapy. You can have energy healing approach like we have in Reiki or pranic healing. You can have a life healing approach where you actually go out into the life, live it out, and wait for some real circumstances to come and they heal you. Or you can have spiritual healing where you use Reiki, pranic healing, certain forms of spiritual practices, and so on. Every healer, if he heals long enough, comes to this principle: everything works on someone, nothing works on everyone. And therefore, what to deploy on whom and how much becomes a craft, not a science. That is where experience makes a difference between two people, that what to deploy where and how much is a craft, it is not a science. Psychoanalysis, what we are going to study, if we look at the above thing, it is an active healing process and analytically driven healing journey. And obviously, it is difficult. Therefore, many people say, I don't want psychoanalysis, give me a pill. So they will say, let chemicals talk to chemicals. I don't want to talk to myself. Second, last time we saw, which we must revise, is how different schools of psychoanalysis have different core concepts at their center, and how this affects the way they analyze the causality of any sickness, what we would call pathogenesis. So, for Freud, the central concept is sexuality. For Klein, it is aggression and envy. For Bion, it is aggression, envy, and containment. What these words mean, as we go into each of these schools, we will elaborate upon it. For the moment, just to drive and communicate a point, that each school has a different conceptual core center. Not that they deny other schools, not that they deny other concepts can exist, but the focus is very clear, that they believe these conceptual centers are more important than anything else in causing pathology. And obviously, what you believe causes pathology will create how you are going to heal it. If you believe the cause of pathology is sexuality, you will focus your therapy on sexuality. If you believe cause of pathology is aggression, you will focus your therapy on aggression. If you believe all of this is useless, it's only biochemicals, you will focus on biochemicals. So healing method will always be a function of pathogenesis. What you believe is the cause, so will your method be of healing. For Winnicott, the core is good enough mothering in early life. For ISTDP, it is the repressed anger, sadness, and guilt. For Jung, the central concept responsible for pathology is individuation and frustration of individuation, and uh, unregulated firing of archetypes. For Margaret Mahler, it is fusion individuation. We'll come to it when we come to the school. For the moment, just be with the word. For Lacan, and here Dr. Mukherjee can help us more, the core concepts are related to desire, primal disintegration, and unconditional love. Dr. Mukherjee, can you add something? You are deep into Lacan.
Oh, sir, absolutely right, sir. Yeah.
In Hindu spirituality, it is desire, karma, self journey, enlightenment. This whole process of karmic self journey for new self experiences, and the search of enlightenment. And before that, experience of that desire pain world, the pleasure pain world, that remains at the center. And I have developed my own system, HEAT, holistic elemental analysis and therapy, which is also largely based upon the core concepts of Hindu spirituality and some of the core concepts that we saw above. It's a kind of combination. Now, last time we saw uh, that if we say that different schools have different centers of uh, focus, then how do we apply it in practice? Let us say a person with OCD comes to you, and the same person goes to all these different schools. How will they analyze the causality of that problem? If the OCD person goes to a psychiatrist, uh, Dr. Parulikar or any psychiatrist, can you help me? How will you look at the center of his difficulty? If a OCD person comes to a psychiatrist, how will the psychiatrist look at the causation of OCD? Any psychiatrist can help us? Please do.
They will describe it in terms of problems with serotonin balance,
Correct.
imbalance of serotonin inside the nervous system, and
Uh,
serotonergics such as sertraline, escitalopram, or fluoxamine are supposed to help.
right,
OCD with insight, without insight may carry some different implications and may allow you to add an antipsychotic.
right,
Uh, but usually, I believe even the uh, all textbooks will accept that it is the pharmacotherapy and psychotherapy together. So they
correct,
should either refer or help the patient with exposure and response prevention also.
right,
And that will be the behavioral approach. And
right,
if we go to analytical approach, then dominance, submission, struggle, ambivalence, disorderliness, the negative traits of the anal stage of development may be important to
correct,
address.
correct. So this will be the psychiatric take on OCD patient. Now say the same OCD patients goes to Ayurveda. So they will talk in terms of sattva, rajas and tamas, that rajas has gone up, or they will talk in terms of the mental component of Agni, that the mental component of Agni is not able to digest certain material which is causing this difficulty. The same person goes to CBT and they will have to anchor the difficulty in either of the three core beliefs they believe in. So the three core beliefs they believe in are uh, I am not good enough, I am not lovable, the world is not a safe place. So the more probable solution will be that somehow the person at a very deep level doesn't believe the world is a safe place or he is safe, and that anxiety is being channelized into a repetitive action that we call obsession or compulsion. The same person goes to a behavioral school and they will say that somehow this behavior has been incentivized or not adequately disincentivized in real life, and there are some secondary gains because of this. So address it that way. The same patient goes to ISTDP therapist and he says it is anger, sadness, and guilt which is bottled up, which when it activates and starts coming up, the anxiety starts. That difficult emotions are coming up, and this anxiety which is covering up all the three is has to be managed some way, and that is going into the obsession or compulsion. Now let us say the same person comes to psychoanalytic schools. How will we look at it? He comes to a Freudian school, and Freud will talk about two possible routes of OCD, an anal route and an Oedipal route. Bhavna, can you explain the anal route or the Oedipal route?
Sir, today I will not be speaking much. I just had a tragic news incoming, so I'm trying to anchor myself still.
Okay,
I'm sorry for that.
sorry for that. So uh, Freud will base the explanation on two ways. One, in the anal stage, there was either too much of orderliness or repression, or too little of it. Too much will cause too much order, too little of it which cause too much disorder. Or there was too much strictness in toilet training or too little strictness, and that will get into the way greed or accumulation or hoarding will happen. Too much control uh, will be too little hoarding, and uh, too little control will be too much of hoarding. Too much control can also give rise to a reaction formation where still you can have too much of hoarding. Freud's second explanation will be that the Oedipal phase has not been uh, well negotiated, and therefore there is castration anxiety, and the castration anxiety is getting into this obsession, that when you cannot negotiate the Oedipal stage, two things happen. Castration anxiety arises, and part of you regresses to the anal stage. And there, the anxiety powers up the repetitive part of that anal stage. And whatever has been the repetitive part, whether it is order based, whether it is predictability based, planning based, hoarding based, that part becomes active in the Oedipal manifestation. If you go to Klein, she will say the split is open. We will come to it what it means. Just note the words for the moment. And because of that, the aggression is being channelized into a repetitive moment, or anxiety related to aggression is channelized into a repetitive moment. So the repetitive movement can be because of anxiety or because of aggression. Now put all this together. Imagine pathology is sitting in the center of a room on a chair, and this room has 7 windows. And when you open the window, you see something. And each school is like a window. You open the Freudian window, you see something else. You open the Kleinian window, you see something else. And in all probability, the pathology who is sitting in the center of the room has 10 faces, out of which we have seen 7 in different schools, and future generations will discover another 3 which we have not seen at all. And only when all of them are put together, somehow a holistic picture will emerge, which is still far away. And at present, we are just trying to put everything together. So what we do now is jointness, not synthesis. So the best we can do is put into practice all the schools and see what works on each patient. It's like for fever, if you have 10 medications, you try one or the other and something works. And as you experience more and more, trial and error becomes less and more certainty happens. Now let us take another example. A person comes with schizophrenia, and one particular type of schizophrenia is delusion of persecution. Now let us confine our discussion to the psychoanalytic schools and see how each school will analyze the causation of this. Freud's explanation is it is repressed homosexuality. So how does it go from repressed homosexuality to delusion of persecution? Freud's mechanism goes like this. He says, step 1, the person sees another person of the same gender and develops a homoerotic impulse, the liking, the attraction. So the first idea that comes in the unconscious is, I love you. This is not acceptable to one's superego, one's morality. So one's superego or one's morality comes and sits on top of this impulse, I love you, and puts into operation a defense called reaction formation. And this translates it into its opposite. I love you becomes I hate you. This keeps developing, and the hatred develops to the extent of murderous rage. So then it becomes I will kill you. Again, superego comes in and uses the defense of projection, because it's unacceptable to the morality of the person that he can have a murderous impulse towards an innocent person. So I kill you is projected onto the person as you will kill me. And when that projection happens, the paranoia starts that he is going to come and kill me. Right? So the mechanism is like this. I love you, I hate you, I will kill you, you will kill me, therefore the paranoia. So the solution there would be acceptance of one's sexuality. The more you accept, the less there will be a hatred for oneself or the other, less the projection, less the rage, and less the paranoia. This will be Freud's explanation of delusion of persecution based upon repressed homosexuality. Come to Melanie Klein. She will say that the root of this difficulty is not really sexual, it is aggressive. So Melanie Klein will say the split is open, right? The aggression has been practiced on an object in fantasy, and now the fear is the object will return back that aggression. So it is the split which is open, and therefore my aggression is now projected out and coming back on me. And I am fearing actually my own aggression coming back. So the solution will be to accept one's aggression, leave it out in a safe therapy situation and be free from it. And when my aggression is lived out or neutralized by love, there is nothing to project out, and therefore there is no paranoia. Carl Jung has a very different take on this. He says that we all have naturally given programs to live out our program of life. Like we all pass through stages like childhood, teenage, puberty, teenage, the young age, and we go out then into the world to earn for ourselves and our family. This, he says, evolutionary speaking, is the stage of the hunter-gatherer. And the hunter-gatherer always faces the predator in his journey. In early days, the predator used to be animals who used to actually live on us, who used to eat us, and now predators are our enemies in the professional world who we believe will attack us and cause us some injury in our profession. Or they are our political rivals, or whoever it is. But anybody that can attack us is for us in a way a predator. So his idea is that when the predator archetype is overactive, right, it is projected out and therefore the paranoia. Kohut has a very different take on this. He says that there is something called self, a coordinator in the mind. And when the self is very weak and it disintegrates, you are no longer able to use defenses well and do repression, and therefore things are projected out and therefore the paranoia. ISTDP has a different take. It says you have a lot of aggression, and because you don't want to own it up, feel it and let it go, or even accept it, you project it out. So your projected aggression is seen as threatening by you. And the solution will be accept your aggression to whoever it is towards, allow it to go where it belongs, feel it fully in the therapy room and let it go and be free from it. And once you have felt fully and let it go, the paranoia will drop. So what we see is that each school has a different take on pathogenesis and therefore different method of healing. So what do we look at is each of these schools? Each school is like an analytic machine. Take example of two machines. We see on the Indian roads people who have a machine to take out sugarcane juice. So there is a sugarcane juicing machine, and there is another machine for taking out juice from lemons and oranges. The small one is for oranges and the big one is for sugar canes. Now, you can't put sugar cane in the orange machine. It's not meant for that. So every machine will accept some particular kind of input. So let us say a patient comes and he says, I am suffering from this kind of delusions. And you know, last night I had a dream. Now, the psychiatrist may not be so interested in the dream because his analytic machine is not geared to process that input. It's not focused upon that. But for the psychotherapist, that is the most important thing. He will go into details of it. If the patient says, 2 years back, I took this tablet and it worked well, that may be very important for a psychiatrist because he has to prescribe, but there's little the psychotherapist can do about it. He won't have any idea of the biochemical action inside. He won't have that knowledge. So his analytic machine is geared to certain kind of inputs only and will give certain kind of outputs only. Now, when we go into each of them, Freud, Klein, Winnicott, ISTDP, each of these schools are like analytic machines, which will demand certain kind of inputs and give certain kind of outputs, and therefore case history taking will differ the moment you get into each of these schools. If you are a Freudian therapist, you will ask more questions on the Oedipus, on the anal stage, on primary and secondary narcissism. If you are a Kleinian, you will ask more questions on presence or absence of mother in the first 2 years of life. You will ask more questions on aggression and envy, and also on greed. If you are a Winnicottian, you will ask more questions on good enough mothering or not good enough mothering. You will ask more questions on transitional objects like teddy bears or a mother's sari or a towel that often children keep with them for a very long time before they give it up. So those transitional objects are very important to Winnicott, not so important to Freud or Klein. If you go to ISTDP person, he will ask for the points where anger, sadness, or guilt would have been generated, because that is what he will try to empty out. So the point is, whatever patient says, everything is important. We may not feel it is important because our training is in a particular analytic machine, and that machine may not be equipped to handle that kind of input. But the same input will be very valuable to somebody who is trained in another kind of analytic machine. So what we are trained in, and the more schools we know about, the more rounded and comprehensive case history we will take. And we will be able to make sense out of more than the patient says. And we will not have to cut short the patient and say, don't go there, come here, what I'm asking you. Because we can then make sense of what he's saying otherwise also. Now the question comes, how to deploy the schools. At present, we can only do a joint deployment. Nobody has been able to synthesize all the schools conceptually. Multiple deployment can be done. In the same session, you may have to deploy multiple schools at different times. 10 minutes, the person may talk of a Freudian issue. Another 10 minutes, he may talk of a Kleinian issue. Another 10 minutes, you can say Kohut at work. So multiple deployment has to be done. Same is true for dream analysis. You can have a dream, and to analyze the dream, you may have to use multiple schools. Say, let's say you have a 10-minute dream. For 3 minutes, Freudian concepts are useful. Another 4 minutes, Kleinian concepts are useful, and so on.
Sir, I have a question here.
Please go ahead.
Within a dream, also sometimes there are certain components which are very specific to a school. Maybe within the dream, there are parts which are totally Freudian and some aspects which are totally Jungian.
Yeah,
Can we have multiple school deployment at same canvas, or we see the whole dream separately in different schools?
good question. Uh, we have to deploy multiple schools in a single dream most often, because as you rightly said, for first 10 minutes of the dream, Freud is more applicable. Next 5 minutes, Klein is applicable, and so on. That is one part. The second part is, uh, in psychoanalysis, whether it is therapy or whether it is dream, every point is a junction. In railway, you have this idea of a junction. Central Railway, Western Railway, trains from everywhere come to a junction. And from the junction go to every railway division. Same way, there are many points in the conduct of therapy or in case analysis where we come to junction points. And those are points of judgment. Okay, from here, should we use Freudian school or Kohutian schools? Because both look applicable. Same for a dream, that there is a point in the dream where an event is described and the event looks such that two or more schools can be applied. Then we use certain ideas like, what is the overall flavor of the dream? and based upon the overall flavor, and at times what is the case history of the person, they help us sort of uh, choose one school over the other, and the third is experience. So there may be a situation of very clean situation that first 5 minutes Freudian, then Kleinian, then Freudian, then Winnicottian, a very clean situation. Or there may be a confusing situation, a junction point. And there, our judgment, the case history, and the flavor of the whole dream that comes into play, and we take a judgment based upon that. Now, if the judgment goes wrong, then when we are discussing the dream with the patient, it will come out that the patient will not feel that the uh, key is moving in the lock and the levers are moving inside, or the interpretation does not make sense. So at a junction point, even if we make a mistake, after we have developed our ideas, when we talk to the patient and we see the conviction of the patient or we see the effect of our interpretation, we can always come back and make a correction. So these are junction points, which is not very clean, that multiple schools seem, all of them seem appropriate at a point. Those are more tricky situations.
Thank you, sir.
Thank you. Okay.
Something, sir?
Sorry?
May I ask something?
Yeah, please.
I think if horny should be important, especially in the
Hello?
character development. Karen Horney,
Ha.
her theory, would that be also relevant in these multiple schools?
Uh, yes, you can do uh, developmental analysis using multiple schools.
Uh, okay.
Right. Like if you take the period of 0 to 2 and you ask the question, what all happens in the unconscious mind of the child in 0 to 2? Right? Then obviously something Freudian also is happening and something Kleinian also is happening. And the ideal will be to consolidate, but nobody has been able to synthesize. So what we say is that these are parallel views of the same time period, that all of this is supposed to be happening. How that is integrated, we don't know, but all these are the claims that this is what is happening at this given time. And for our purpose at any given case, any of that can be relevant. So on my channel, there is a series called um, The Confluence of Schools, where I
Okay.
have tried to do, if you look at 0 to 2, how can we put together Freud and Klein? Or if we look at Oedipus, how can we bring Klein into Oedipus? How can we bring in Kohut in the Oedipus? Right? Can the same phenomena be explained, inviting other schools to be a part of it? So that school synthesis is something that is remaining, but I have made a some attempt at it, and there is a series of lectures on bringing together the schools.
Thank you.
Thank you. So now let us look at who are our patients and who are not our patients. A very important thing. Every school develops its own omnipotent narcissism, and that we will also develop when we stick to a school. So we tend to believe over a period of time that whatever we are trained in is universal. That is a kind of a narcissistic fanaticism which we all develop whatever we are doing. So when a patient comes, this idea will never come to us that maybe he is not our patient, that what we are trained in is not really efficiently geared for this kind of situation. Right? So what we believe is that what we know can efficiently treat every type of patient. And this wrong belief is universal. Every school has this belief. And then there is this practical constraint that we all have to make money. And we are all desperate for patients. So nobody is going to ask a patient not to come to him. That's a commercial constraint that very few people can say that I will not be able to help you efficiently. More efficient will be this school, you go there. Right? So very few people will do this, right? So this requires two things. One, a clear knowledge about which way of healing is efficient for which situations. And two, ethical honesty to tell the patient that what I am trained in is not most efficient in your situation. You will have a better choice if you go to X. Right? So this is very important, but how do we make that kind of thinking is what we'll discuss today. So pathology can be mild, moderate, and strong, and corresponding to it, therapies can also be short-term, medium-term, and long-term. So we make a correspondence. Mild problem, short-term therapy. Moderate problem in intensity, medium-term therapy. Strong problem, long-term therapy. Earlier, the problem's roots are more he will move towards medium and strong, moderate and strong. Later are the roots, more likely movement will be towards mild. Short-term therapies can be CBT, DBT, REBT. Medium-term ISTDP is a good option. Medium or long-term psychoanalysis is a good option. So psychoanalysis is not a short-term therapy, neither in terms of learning nor in terms of practicing. Even learning takes longer. CBT, REBT, DBT, you can do a few courses, 6 months, 7 months, 1 year, and you can start off. Psychoanalysis takes a longer time to really develop a grip. You can start off very early, but grip development takes time. Otto Kernberg has divided patients into 4 groups for psychoanalysts to focus upon. Group 1 is the strongest and the most functional patients who can even take up a challenge in the therapy session. So you can practice confrontation and challenge with these patients. They will neither disintegrate, nor they will start weeping, nor they will go out of therapy. So one group will be strong enough to bear challenge and confrontation. This is the ideal group for ISTDP because ISTDP is based on use of challenge and confrontation. Group 2 are patients who are slightly fragile compared to group 1, but they are not really fragile. Let me say they are not as strong as group 1. So they may not be able to handle challenge and confrontation, but they can easily handle interpretation. So this is the ideal group for practicing Freud, Klein, and Bion. Group 3 will be patients who are weaker than group 1 and group 2. They cannot bear challenge and confrontation. They cannot bear interpretation. They need holding. So if you are practicing Kohut, which is more based upon holding and support, then it is more based upon holding, support, and empathy. Right? So this group is very good for Kohut. And the idea will be, if these patients come to you, you start with Kohut's approach. Initially, don't make any harsh interpretation. Just be supportive, provide holding and empathy. And after some time, when the patient develops the capacity, take him to group 2 for interpretation. So first you do holding and then you do interpretation. Group 4 will be that group which is so fragile that they cannot take any kind of psychoanalytic therapy. Right? The very frame of therapy, that you have to come to a given place at a particular day and time regularly, that you have to lie down on the couch or be on the chair face to face, that you will reveal everything about yourself, but the therapist will not reveal anything about himself. That he will provide interpretation whenever you are trying to take a way out and justify yourself. That basic things they cannot take. So that group Kohut says is not for any form of therapy. Right? So the idea is, look at the case and be very clear which analytic machine this case can be put into. Right? So don't put the case into a wrong analytic machine. Don't give ISTDP to a person who needs holding. Don't give interpretation to a person who needs holding. Don't take a patient who cannot take any form of psychotherapy. Send him to somebody who is into existential humanistic therapy or logotherapy or mild forms of CBT. Right? So don't put case into a wrong analytic machine. Don't put a patient into a wrong type of therapy. So this is very important. Given a case, given a pathology, given the intensity of pathology, which is the right therapy for the person. So if we have a perspective of different schools, we can take a good decision on this point. And that is what we will be doing. We will be developing a perspective of multiple schools. So who is our patient then? Apart from the above analysis, you also have to look at whether he has time, money, interest in the inner world. Very important. There are many people who are not interested in the inner world. They will say, I don't want to talk these thoughts and feelings and what is happening inside me or what happened in my childhood or what does my dream mean. Just give me a tablet and forget about it. So the person has to have interest in the inner world, intellectual capacity to engage in the conversation about the inner world, and emotional capacity to bear the feelings when they arise. So intellectual capacity, emotional capacity, financial capacity, time and interest, these are very important. And this is our patient, and meaning patient of psychoanalysis. And then we have to look at the group 1, group 2, group 3, group 4, that if he is a patient of psychoanalysis, then which school? So the first is he patient of psychoanalysis or not? Second, which school will most efficiently benefit him? Who is not our patient? Certain things psychoanalysis is not geared to efficiently address, right? So every school, every approach has limitations. Psychoanalysis has these limitations. We are not very good in dealing with severe mental retardation, strong antisocial personality disorder, florid psychosis, difficulty in extreme impulse control, and violence prone individuals. 1, 2, if in intensity something goes into the severe category and becomes so florid that the person just cannot sit in the therapy room and do therapy. If it becomes so severe, then there is no way out but to make use of medicines and calm down the person in an emergency. And only when the person becomes calm enough to participate in therapy can the therapy start. Okay. So this is about who are our patients, who are not our patients, and if somebody is our patient. So who are not our patients? People in severe acute crisis. Right? It may be a crisis of trying to attempt a suicide. It may be extremely florid psychosis. It may be extremely florid impulse control problem. It may be extreme form of violent behavior, extreme form of mania. These extreme situations, we can't do anything. You require medication to calm down the person. Second, severe mental retardation, strong antisocial personality disorder, right? Very strong forms of autism. There is little that we can do. Right? Rest of it, we can uh, make an attempt, which would mean if you go to DSM-5, out of 22 chapters, there are 4 chapters where we can't do much. Right? 5 chapters, sorry. And there are, sorry, 4 chapters and 18 chapters where we can considerably make a difference. So I have done a psychoanalytic analysis of what happens in those 18 chapters. There is a complete series on my channel, Psychoanalysis and DSM-5. So out of 22 chapters, 4 chapters are very bio-heavy or they are acute in nature. Rest 18 chapters, we can do something in all the non-acute cases. Right? And this forms the universe of our patients. And in the universe of our patients, we have to segment which school will benefit them the best. Carl Jung used to say, why people are not eager to come to therapy. Out of 100 people who need help, only 50 will ask for help and 25 will leave the therapy in less than 10-15 sessions. Now, why this happens? So Carl Jung used to say, the most terrifying thing in the world is to know oneself completely. It is so difficult to navigate the inner world that many people don't want to do it, or they start and they drop midway. They can't take it any further. And this is where the holding part of Kohut becomes very essential. That we have to be patient if the client cancels one or two appointments. We have to allow that to happen. If the client cannot take our interpretations, we have to go back to the holding phase, because it's not easy to see oneself and navigate one's inner world. Any questions on this? Yeah, please.
So sometimes it is to do with the resistance in the patient, where they do not have an inner permission for the interpretations. How
Correct.
long and on what criterias we can keep on just continuing with the holding phase?
Uh, it's an interesting question, and there are two aspects to it, right? There is a resistance aspect to it, and there is a capacity aspect to it, right? Resistance meaning you have a difficulty in owning up something in yourself, and capacity meaning you want to but you cannot. The feelings which that owning will generate, you don't have the capacity to really withstand that feeling. So if it's a capacity problem, then we call it a fragility problem, right? So fragility problem, that needs time, because deep inside the system knows it cannot handle this kind of release of feelings. So the system itself is generating resistances to overcome the capacity problem. So that is first, that we have to allow people the time, right, where the capacity develops. And often the capacity develops by three, four things. One, internalizing the good, reliable, stable object that the therapist is. Two, slowly as interpretation chips away with defenses, more and more things become conscious, and in slow packets, the repressed feelings are released. Right? And three, the unconditional acceptance by the therapist enables the patient to overcome the fear of attack and express those things he finds it too difficult to express elsewhere. Right? Fourth, he uses the system of the therapist for containment. And once he sees a good container, he internalizes it. So those are the ways in which fragility is taken care of. But fragility always needs time. Even in ISTDP, which is supposed to be one of the most intense and quickest forms of therapy, right, they have come to the conclusion that in severe fragility cases, they need 150 sessions to overcome the problem. 150 sessions means practically 2 to 3 years. It's no longer short-term therapy anymore. So even the shortest of therapies find it difficult to overcome the fragility problem, right? So fragility, we have to be patient and give time. This can create guilt, I agree with you. And this is typical dilemma for Kohutian approach. That if a narcissist comes to us, Kohut would say, don't interpret the narcissism. Allow him to live it out in the therapy room. If you interpret, it will be repressed more strongly and more deeply. And that is where the dichotomy is. Classical psychoanalysis will say, you are colluding with the pathology by not interpreting. Kohut will say, by interpreting, you are repressing it deeper. So there is a 180-degree opposition. Now, in Kohutian approach, you can have a guilt feeling that I am taking money from this person. So many sessions have gone and nothing is happening. Right? Or you can have doubts about yourself. Am I a good therapist? Why nothing is happening after so many sessions? So this is a judgment point that in Kohutian approach, when we give time, one, we should be very clear we are giving time because of capacity problem, fragility. Second, we have to address our own guilt that this time is justified. This is one part. Second part is related to repression. That when the resistance is because of repression, right, then it's a different situation. Then we have to interpret harder, right? And there, one may be led to a situation where one has to do what is called head-on collision. It's a confrontation method, very used in ISTDP, where you say that since you say there is no problem, then I wonder why you are with me. It's a very hard interpretation. Or you can say, if you say that there is repressed anger, but you just can't bring up that anger and feel in therapy and let it go. So let us then just accept that this is what it is. We can go no further. And then you will have to live with whatever that repressed anger causes. I know it will be difficult, but there seems to be no choice. We just have to accept it and accept the pain that it brings. So this is what is called head-on collision for very strong repressions. There is one more technique of bringing yourself in by asking the patient, what feelings are coming up towards me in your body right now? So what you do is, the patient has feelings towards X, mother, father, whoever, husband, whoever. You become a screen to transfer those feelings to you. Right? You are soliciting a transference. You want a displacement to happen in the expectation that maybe it is easier and guilt-free to feel it towards you than to feel it towards mother or father. And you can use statements to ease out. For example, the moment you say, what feelings are coming up towards me? He will say, I don't have any feelings towards you. Why should I have? I come here 1 hour per week. Why should I have feelings towards you? It's just a professional service. And then you bring up statements like, it is sad to know that you don't relate to me. You don't find me worthy of relating. That you don't find me safe enough to allow your feelings to go towards me. I really feel sad about it. Or you can say, you can have feelings towards me because I'm in front of you. Not because I've done something, but because I'm in front of you. And whoever is in front of you, there are bound to be thoughts and feelings towards that person. Or you can say the cost benefit argument. If you say you don't have any feelings towards me, then we will have a feelingless relationship and the resultless relationship. What kind of relationship is that? Do you and I want that? That is why are we here? To have a feelingless, lifeless relationship. So these are some of the arguments, some of the ways, the technique tools, so to say, right, to solicit and break through the resistance. Right? But you are right, when the resistance is very, very strong, right, you may not be able to break, and you may either have to just accept it, which will cause lot of guilt, or when you try harder, the patient will leave. This will happen largely in cases of fragile narcissism and schizoid personality disorder. Because as the schizoid person comes to you for therapy, after some sessions, emotions will develop and he's terrified of closeness. That is why is schizoid personality disorder. Because the template in his mind is relating brings tremendous pain. It's unbearable. And it has happened in the past, and I have created a formula for future, never again. That once it happened in the past, and that time I decided never again. And I can't risk it. So in schizoid, it happens. In fragile narcissism, it happens that either we feel guilty of not delivering after taking money, or we just feel inefficient. We feel something is going in the wrong way, and the moment we try hard, the therapy breaks. So there is a joke in therapy. It says, "Brilliant interpretation and the therapy ended." Right? We don't have to do that. Yeah. So sorry, Bhavna. Yeah, Bhavna, have I answered your question? Or
Just there's another part two to this question, if I may.
please go ahead.
Um, let's pick up an example. For example, we have taken a patient who has a good capacity, but there's in during the therapy, it's been around 20 to 30 sessions, and there is a point where the core problem ka resistance is coming. Is it okay, even if we have been throughout those 30 sessions, we have taken the approach of Freudian system, but the moment the resistance comes up, for that containing, we is it okay from the therapist point of view to flip to a personal centric approach, meanwhile, to provide the holding and development of other faculties to get rid of the resistance to increase the capacity?
Correct. It's a very good idea. Often we'll have to take a detour because the straight approach to the core is too unsettling to the patient. Okay? This is what used to happen to me early in my practice, and I lost many patients because of it. What used to happen was I was very good in pathogenesis, multiple school pathogenesis. So the moment I would take case history in the next 15-20 minutes, I will be clear about the pathogenesis in terms of multiple schools. And then I had this omnipotent narcissistic idea that why go from the leaf to the branch to the trunk to the root? Why not go straight to the root when you know what it is? I was young and rash. It does not work that way. I would go straight to the root, and it would be so unsettling that the patient will leave therapy. And that brought me to this uh, idea that we have to be patient and we have to move from the leaf to the branch to the trunk to the root, even if we know the root right after the case history. Right? So, because he needs time to heal himself, he can't go quick beyond a particular point. Right? And that becomes very apparent when we ourselves become patients. And I always do it. Whenever I learn a method, first I become a patient of that method. So when I learned ISTDP, I went as a patient to the ISTDP person. So it tells you firsthand how does it feel on the other side of the table. And it's very different. It's very, very different. Right? So it's good to take a detour. It's good to be patient. And when to do it also depends on the specifics. For example, uh, when do you become uh, very aggressive in interpretation, and when do you become easy? So if you say somebody is resistant, I have taken 15 sessions, I will say it's nothing. Don't even make a judgment of being resistant. Right? If you say I have taken 120 sessions, nothing is moving, I will say yes, resistance. So don't judge somebody being fragile or resistant in quick 10, 15, 20 sessions. One of my teachers used to say something very important. When he was teaching me, and I brought my first case for supervision, my first therapy session. So he didn't even look at the transcript. He asked me a question. He said, "What is the objective of the first session?" I did not have any answer. Right? So I gave some answers. Find the case history, look at the core defenses, this, that, and the other. He said, "Forget all of that. Let us talk common sense." Right? He says the objective of the first session is to seduce the patient for the second session. Then he said, "What is the objective of second session?" He said, "Seduce the patient for the third session." Because first 5 sessions don't even look at the productivity. Just look at the safety, the trust, the familiarity the patient develops. Right? Because if you try to be very aggressive, it becomes unbearable and the patient leaves, nothing can be done. no school can be deployed, right or wrong. So the first condition is the patient should be in therapy for any school to be deployed, for that matter, for any tool that we know to be deployed. If his being in therapy is threatened by any activity of ours, that is a high risk activity. Yeah, Dr. Paralikar, you had a question. Yeah.
In the group one, we said that the confrontation and challenge were indicated, and that indicated good strength in the patient. Whereas in the group three, we said that the patient is fragile. I am not remembering exactly what was accompanying that, but fragile narcissism or something like that, where holding was required. And how do we differentiate between the two?
Yeah.
And the Erhard seminar training was in our textbook. So, does it apply to group one? Where you can confront, assault the patient directly.
You can confront patient.
Directly
Huh.
kind of accuse the patient of bad motives or that Erhard seminar training. And if the patient survives, then he comes out as a better equipped person. If your
Correct.
choice for the therapy was correct in the first place.
Correct. So those who are at first level can obviously take that assault on the first level. Those who are in the second, after some therapy and healing, they may go to the first. Right? And that will be like a test of fire for them. Now, how do we make out which group the person belongs to? That's a very tricky question. One simple answer, which is not a very reliable answer, is this. You can go into using questionnaires which measure ego strength. Right? So if the ego strength is high, he is more likely to be higher in the group 1 or group 2. If the fragility is more likely to be group 3 or group 4. One way of looking at it. Second way is what happens when it comes to the session. If he is just too anxious all the time, and uh, the moment you say something, he takes it as an attack and becomes even more anxious, and that does not reduce with sessions, then we have to look at 3 and 4. How do we differentiate between 1, 2, and 3? If we give an interpretation, then that is like chipping away the ego. You take a scoop out of the ego, and the idea is you go down and bounce back to health. So every interpretation will make you go down from where you are, and then you bounce back to health. Right? If that bouncing back capacity is not there, and the interpretation, instead of causing some healing, causes disintegration, right? And the person is in the anxious, chaotic state for some time, then we know he is not ready for interpretation as yet. He requires holding. One more way, what is most scientific is the pathway of anxiety. Now, this is an ISTDP concept, and you can see video recordings if you go to their seminars. Right? And any of us who is doing ISTDP, when we do supervision, you can bring the video recording of a patient, and you can see in video, frame by frame, right, how the anxiety is moving. And that gives us idea about fragility. For example, I ask the patient, uh, what is troubling you? And he says, I was beaten up and humiliated by my father at the age of 16, and I just can't get over that memory. So then I say, when you think about that incident, do you remember how it occurred, where it occurred, the color of the walls, how the doors were, how the grill of the window was? Can you go back to that situation? He goes back. He says, yes, I can describe it. Then I say, what feelings are coming up towards your father in your body right now? And there are 4 options. He actually feels rage in the body and he does like this. So this clenching of hands, clenching of legs, and the jaws clench. Because this is the natural movement of anger in the mammalian species. Right? That when we are angry, that energy is supposed to go into our hands, legs, and the jaws. Right? Jaws to bite, hands to grab and destroy what you are angry at, and legs to kick. Right? Or in case of flight and continuous anger, to flee also. But anger will go in three parts: contraction in the legs, contraction in the hands, contraction of the jaws, the natural mammalian flow. Now, if he says this, he is in group 1. I asked him about anger. Anger has come up and gone where it has to be. It has to go the striated muscles, which is where the anger is supposed to go in a healthy situation. So group 1. Second group says, I can't think. I seem there is like a fog in my mind. So we say the anxiety has not gone into striated muscle. It has gone into cognitive perceptual disturbance, which means the man is fragile. The capacity is still not there. Right? So the anger is not going into striated. Rather, the upsurge of anger is causing anxiety, and the anxiety is not allowing him to think clearly. Or he will say, my vision is blurred. Right? Another manifestation of anxiety. Or he says, I feel a whistling in my ear like vertigo. Another manifestation of anxiety. Or he says, my hands and legs have completely gone limp. There is no tone of the muscle, which means the anxiety is so high, he is in group 4 or group 3. Group 2 will be, the third group will be that anxiety goes into the stomach and he says, I feel nauseating feeling. Which means anxiety has gone into the smooth muscles. They have not gone into striated muscles, which means he is fragile. But they have not disturbed the cognitive perceptual disturbance, so he's not that fragile. So the moment you ask for feelings, the pathway of anxiety will help us to decide the fragility. Right? And this has been video recorded many times. So this is like with evidence, what you call evidence-based medicine, so evidence-based psychotherapy, so to say. ISTDP is the only school which records sessions. In all other schools, it's called a breach of confidentiality. Actually, it's a taboo. Because the moment the camera comes into the room, we believe society has come into the room. Right? And the third should never be present in therapy. So there is a 180-degree divergence between ISPDP dealing with confidentiality and other schools dealing with confidentiality. So if we can have those videos, one of them, any person who is practicing ISTDP, right? So they take that in writing from the patient that can I use your videos for supervision? If the patient says yes, only then you do it. So if somebody is practicing and somebody has consent of the patient, we can use those videos for supervision. And there you can see frame by frame the movement of anxiety as the feelings come up. Right? And you can also see junction points. That when I say X and the patient says Y, now a junction point has come. Should I be Freudian? Should I be Kleinian? What should I do? 4-5 paths are open now at the junction. And that partly is craft by experience and partly it's trial. That even after experience, nobody can be 100% correct. There's nothing like a mistake-free life or a mistake-free therapy. So you can always make a mistake, but the moment you make a mistake, you know after a few moments that it's not going as I wanted, so you can come back. So this is one part of it. Yeah, please.
Thank you.
Oh, thank you so much.
Elucidating.
Yeah. So now let me start the second part of today. Or you want a break, or should I start the second part?
Perhaps I can take a coffee while the session is on.
Yeah, please go on. So let us have a 5-minute break, have
Uh,
coffee, and then continue.
Thank you, sir.